Bismillahirrahmanirrahim. Today I'm going to talk about the failures in fixed prosthodontics, failures in fixed prosthodontics. The failures and complications in fixed prosthodontics can be classified into biological complications and failures and mechanical complications and failure. The biological complications and failure including dental caries, periodontal disease, occlusal dysfunction, need for root canal treatment of abutment because of acute pulpitis or loss of vitality. And the last one is the abutment tooth fracture. As we said before, the most common complications of the biological and mechanical failures in fixed prosthodontics is dental caries. Regarding the abutment tooth fracture, the fracture could be coronal tooth fracture or root fracture. As we said in this example, there is coronal tooth fracture of anterior abutment of 3-unit FPD. The causes of the coronal tooth fracture including over reduction, the over weakening of the abutment tooth by over preparation, or it could be recurrent caries, secondary caries around the margin of the FPD or crown retainer, or it could be a result of trauma or excessive forces during seating or removal of the crown or FPD. The management of the coronal tooth fracture. The large coronal fracture around partial coverage retainer, if it is around the partial coverage retainer like 3/4 retainer or 7/8, then the management of this fracture is full coverage restorations to cover the fractured part, and tooth may require separate pin retained restorations if it is vital. If the fractured tooth is vital, we should build it with pin retained restorations, then prepare it to receive full coverage crown or full coverage retainer. If the fracture of the coronal tooth structures expose the pulp, the management of these complications include endodontic treatment, post-anchor build-up, then abutment preparation for crown or for full coverage retainer of FPD. The abutment tooth fracture handled for coverage restorations usually horizontally at the level of the finish line. Uh, this necessitates removal of the prosthesis, endodontic treatment, post-anchor, and new prosthesis. Regarding the root fracture of the abutment tooth, the expected causes of these complications include excessive widening of the root canal during preparation of the root canal to receive the post, either prefabricated or custom post. We can see in this example there is excessive widening of the root canal to receive custom post. The second cause is forceful seating of the post anchor, tight fit of the cast post or prefabricated post, especially the cast post. It is tight, it will result in accumulation of internal stresses and vertical root fracture. Always, the post should be always passive, either prefabricated or custom post. It should be always passive inside the root canal, or short post because of inadequate retention, which result in mobility and leverage of the root tooth structures and resulting in vertical fracture or root caries. And the last cause is trauma. The management of the root fracture of the abutment tooth. If the patient has several endodontic treated teeth and have been restored with both anchor and crowned or used as a retainer for FPD, and the patient complain of pain related to this restored teeth, the possibility of the root fracture should be considered, especially if there is uh, radiolucency around the fractured root. As we said in this preapical X-ray, there is radiolucency. After removal, you can see there is a vertical fracture of the root. The management, if the root fracture are below the alveolar bone, it must be extracted and new prosthesis is fabricated. Sometimes the fracture terminates at or just below the alveolar bone. In such cases, surgical crown lengthening or orthodontic extrusion can be done to expose the fracture site and to fabricate new prosthesis, either crown or FPD. The second categories of complications and failures in fixed prosthodontics is the mechanical complications and failures. The mechanical complications and failures include material complications, which include fractured connectors, fractured porcelain veneer, loss of retention, occlusal wear and perforation, and the last one is the poor aesthetic, or it can be considered as a separate group called aesthetic complications and failure. The first mechanical complication and failure is the fracture of the connector. Fractured connector that connect between two retainers or between pontic and retainer. The most common is related to connector between pontic and retainer. The causes of this mechanical complications include: first one, an improperly fabricated connector during waxing and casting. There is casting defect because of the presence of internal porosity inside the connector, which weaken the connector and become more susceptible to fracture under occlusal forces, or reduce connector dimensions, especially for the reinforced glass ceramic like lithium disilicate glass ceramic or lucite reinforced glass ceramic. The dimension of the connector should be 3 by 4 mm in anterior teeth and 4 by 4 mm in the posterior area. If it is less than this dimension, it will be a weak connector and more susceptible to fracture under occlusal forces. Or patient with heavy occlusal forces like parafunctional habits, always the proxer patient and clincher patients have occlusal forces above the average, and the fracture of connectors are common among these patients because of the heavy occlusal forces. The second, mechanical complications and failure, fractured the extremely small gap with extremely small gap width can prevent solder flow and lead to an incomplete or weak joint. Sometimes the connectors, there are two types, either cast connector, rigid cast connector, or soldered. Soldered, which means the complex FPD are casted as separate parts, then soldered at the connector area. If this cap is small, is extremely small, this means the solder will not flow properly to fill all the gaps between the pontic and retainer, and this will result in incomplete joint or connector or weak connector, or in the case of long span FPD, such like in this case 5 units FPD, there is long span, it is long span, and this will result in friction of the FPD during mastications, and the friction will result in fracture of connector between the retainer on the last abutment and the mesial pontic. The diagnosis of fracture connector is difficult, and the patient will come to the clinic complaining of discomfort from the overloading of the posterior abutment. Like this, the extra force is typically transmitted to the abutment teeth, and discomfort from the overloading the periodontal ligaments may draw attention from the location of the actual problem. And if the abutment teeth have a good bone support and minimal mobility, the fracture connector can be very difficult to detect clinically. This is an example of fracture connector between the full coverage anterior retainer and the premolar pontic. The patient complaint is discomfort and pain related to the posterior abutment because of the cantilever and overloading of the posterior abutment. We can use wedge to increase the separation to see the or to detect the fracture connector clinically, or we can use lobe to magnify this area to detect the space or the gap between the anterior full coverage retainer and the pontic. The treatment, if this bars can be removed intact, the treatment can be either soldering in the lab. If we can remove the fractured bar intact without damage, it can be soldered in the lab or remaking a new FPD. The second mechanical complications related to the materials include fractured porcelain veneer. Fractured porcelain veneer. The causes of these complications either incompatible thermal expansion coefficient between the framework and the layered ceramic. The coefficient of uh, the coefficient of thermal expansion of the metal framework and the layered ceramic should be compatible. Otherwise, there will be fracture of the porcelain or improperly designed framework, either metal or ceramic. It should be properly designed with uniform thickness to provide support of the veneering glass ceramic. Or if there is occlusal contact across the metal ceramic junction, like this case, there is a contact uh, on the junction between ceramic and metal. The junction between ceramic and the metal should be away from the occlusal contact at least 1 mm. This fractures of the labial ceramic veneer of anterior FPD because of incompatibility between the metal alloy and veneering glass ceramic. Or patient with heavy occlusal forces like proxar patients, patient with parapuncture habits, or if the porcelain thickness greater than 2 mm because it is brittle. The ceramic is brittle. If the thickness is more than 2 mm, the risk of porcelain fracture is high, or the fracture could be a result of trauma or long span FPD, such like this case, because of the friction of the FPD during function. This is an example of porcelain fracture. This fracture because of uh, inadequate metal support, inadequate metal support, and this one because of occlusal contact across the metal ceramic junction, and this one improper metal selection. There is incompatible coefficient of thermal expansion between the metal alloy and the veneering glass ceramic. What is the management of fractured porcelain veneer? If the patient has a fractured porcelain on satisfactory multi-unit complex FPD, an attempt to repair rather than to remake. Why? To save the patient additional discomfort, time, and expense. And the porcelain repair system use adhesive primer called silane coupling agent to promote bonding between the silica-based ceramic and the composite resin cement. Uh, this repair is considered as a temporary. It is not permanent or long-lasting repair, but it has advantage of saving the patient additional discomfort, the patient time and expense, but it is still temporary and cannot surface in a long term. Um to ensure long-term success, the management of the fractured porcelain veneer is to remaking new FPD. Then the the management either temporary, which include chairside repair with the composite, including uh, including the use of silane coupling agent, which acts as an adhesive primer to induce or to make chemical bond between the composite resin and the silica-based glass ceramic. And this is temporary repair, while the long-term management or treatment is the remaking of complex FPD. Or there is another repairing uh, which is more permanent by fabricating metal ceramic in the lab. Metal ceramic in the lab. The repair with the composite, either with the use of the silane coupling agent, or we can use the micro-mechanical retentions, either by air abrasion of the fractured porcelain, or by using hydrofluoric acid, 9% hydrofluoric acid, to etch the glass ceramic. It is used only for the glass ceramic like AMAX, while it is not working with the polycrystalline ceramic like zirconia. Then we can use mechanical undercut. We can use mechanical retention like perforation, like holes. We can use air abrasion by aluminum oxide to increase the mechanical retention, or we can use 9% hydrofluoric acid to etch the glass ceramic only and not the zirconia. This is an example of repairing small fractured porcelain veneer using composite and silane coupling agent and hydrofluoric acid. The hydrofluoric acid is applied to etch the glass ceramic. After that, the silane coupling agent is applied, and then composite adapted, cured, and finishing and polishing of the composite repair. And this is the final result. It is okay for if the fractured porcelain is small. There is another method of repair which done outside the patient mouth in the lab. It is considered as a more permanent repair uh, by making metal ceramic restoration to fit over the fractured original. This technique is appropriate when the bond thick rather than the abutment retainer has fracture. We can do this management or this repair if the fractured porcelain on bond thick. The disadvantage of this technique is weakening of the connector during preparation. You can see here there is an example of fractured porcelain on the pontic of FPD. If it is on the pontic, we can prepare the labial surface of the pontic to create more space, and we can drill holes for retention, wax up of metal, pin retained metal ceramic restorations. After casting, applying the glass ceramic veneer, and after that, we try it inside the patient mouth and cement it with resin cement. It is considered more permanent technique compared to the uh, composite resin, but the fracture should be on pontic, and the disadvantage is the weakening of the pontic and connector because of the preparation and making holes for retention. Coming to the loose abutment retainer, the loose abutment retainer, one of the mechanical complication is the loose abutment retainer. What are the causes of loose abutment retainer? Inadequate tooth preparations, either over reduction, over convergence, short preparation, insufficient retentive grooves or pins, and partial coverage restoration. You can see here an example of over prepared, short, and over converged uh, abutment, which will result in poor retention and resistance of the final restoration. The other causes of loose abutment retainer is improper FPD design, such as long span FPD. The long span FPD, like this 5 units FPD, replacing the second premolar, two premolars, and first molar. It is 5 unit long span FPD, which will flex more during mastication, and the flexion of the long span FPD will result in debonding or loosening of the weak retainer. Um, fixed FPD for a case with a pair abutment. This is an example of pair abutment. If it is restored with wrong design or improper design, like 5 units fixed FPD, the pair abutment will act as a fulcrum, and this will result in the bonding of the weak retainer, which is usually the anterior one, or partial coverage retainer for long span. It is the partial coverage retainers has little retention and resistance compared to the complete coverage. If the bridge is long span, it will result in debonding and loose partial coverage retainers. If the In case of long span, we need to make or to fabricate full coverage retainer to achieve the maximum retention and resistance of the FPD during function. Or a poor cementation technique. If there is a failure during cementation, there is contamination during cementation, or wrong powder to liquid ratio. Uh, this will result in cementation failure, dissolution of the cement around the margin of retainer or crown, and finally debonding and loosening of the abutment retainer. Or if there is caries and micro leakage, this will result in loose abutment retainer. How can you diagnose the loose abutment retainer of FPD? Also, it is difficult to be detected clinically, and always the patient complain of bad taste or smell, especially if the abutment tooth is root canal treated or become non-vital. The patient complain of bad taste or smell rather than detecting movement of the loose retainer, especially if the FPD is supported by several abutment teeth. It is very difficult to detect the loose abutment retainer, and the only complaint of the patient is bad taste and smell. This is an example of loose abutment retainer of FPD, which result in severe tooth destructions. The severe tooth destructions of the abutment tooth may be result when a loose retainer gap undetected. Looseness of one retainer can occasionally be observed directly here when force is exerted in occlusal direction. we can notice the movement of the retainer. If the water is sprayed around the margin and the force exerted in opposite directions, air bubbles will appear around the margin of the loose retainer. Uh, what is the management? The FPD should be removed. FPD should be removed using either hemostat forceps because it is loose. It is easily removed. Then the restability of the abutment, if it is carious, all caries should be excavated and re-evaluated for restorability. Either it is restorable or non-restorable. It may need root canal treatment and build up, then new FPD fabrication. If the retainer is not loose, it is better to remove it by sectioning rather than to try to remove it intact by any instrument like spring back action crown remover or pneumatic crown remover or hemostat. If it is permanently cemented and the retainer is not loose, it is better to section it to sieve the abutment tooth. Otherwise, the heavy removing force could be result in fracture of the abutment. If it is loose, it can be easily removed with a hemostat or crown remover. This is the sectioning technique to remove crown or FPD. It is the safe technique to sieve the abutment teeth. It is the best and safe if the restoration is permanently cemented, either crown or FPD. It should be safely removed by sectioning technique rather than trying to remove it with an instrument uh, like crown remover back action or spring back action or pneumatic or any other instruments. This is the different instrument for crown remover. This is called Flex crown remover, and this is Meta Lift crown and bridge removal system. Each one has different system and technique. This is plier. This is pneumatic crown and bridge remover, and this is the conventional back action crown remover, and this is spring activated crown remover. But the safest technique to remove permanently cemented crown or FPD is the sectioning technique. Why? To sieve the abutment teeth. The Coming to the occlusal wear and perforation mechanical complications and failure. An accelerated occlusal wear of the prosthesis, either crown or FPD, can be produced but are due to the causes are heavy chewing force, such as patient with bruxism and clenching, or faulty preparation. The faulty preparation means insufficient occlusal clearance, which means insufficient thickness of the restorations, either metal or metal ceramic, and this will result in a long term in occlusal wear and perforation. When the occluding surfaces are restored with the metal, a casting perforation may develop after several days. since occlusal metal thickness is limited by the amount of occlusal reduction, which means insufficient occlusal reduction will result in sufficient metal thickness, and the complication will be wear and perforation. The disadvantage or the complications of the casting perforations include leakage, cementation failure, dissolution, the leakage, cementation, cement dissolution, and caries, and ultimate failure of the FPD or crown. The last mechanical complication is poor aesthetic, which can be considered as a separate group called aesthetic complications and failures. Aesthetic complications and failure. The poor aesthetic result from the poor communication between the dentist and the technicians. Always the success of any dental treatment, especially the fixed cast restorations, needs good communications between the dentist and the technicians. Also, the opaque application, if the technician apply too thick opaque, and this will result in opacity of the ceramic veneer and poor aesthetic. Also, the lack of knowledge regarding the principles that should be considered in designing anterior teeth restorations. The dentist and the technician should have a knowledge regarding all the principles that should be considered during designing the anterior teeth crowns and FPD. These principles including golden proportion of the width of anterior teeth, the width to height ratio of anterior, the golden proportion should be 62%, and the width to height ratio should be 78 to 85%. Also, the dental midline should be parallel to the facial midline, should be vertical and parallel to the facial midline. Also, the axial inclination of the anterior teeth, the embrasure, the contact, the proximal contact, all these principles should be considered. Also, the symmetry, you should be symmetry. The left side should be a mirror of the right side. If there is any difference in the central incisor and canine height and misaligned midline, this will contribute to the lack of symmetry. Such in this case, there is a difference in the central canine height. This is the height of central, and this is the height of canine. There is a difference between them. Also, the misaligned midline, also the midline, the dental midline should be parallel to the facial midline, and this will result in a of aesthetic, lack of aesthetic, of symmetry, and poor aesthetic. A common cause of uh, poor aesthetic of anterior teeth is inadequate tooth preparation, especially in the cervical third and in the interproximal area. This is an example of this case because of inadequate tooth preparation in the labial, in the cervical third of the labial surface and interproximal surface. There is no enough space for the porcelain layer. Either the technician will apply only opaque and result in opaque restoration, or it will build enough porcelain layers, but the final crown will be over contour. Over contour. Careful communication based on a thorough understanding and knowledge of relevant laboratory procedures. Color science is essential. Also, this is an example of poor aesthetic because of inadequate lab procedures. Like this case, there is a bubbles have been made this metal ceramic restoration unacceptable. Here, the air bubbles will result in poor aesthetic, and this is because of multiple firing. The multiple firing will result in deep vitrification of the porcelain, and the final restoration will be will result in poor aesthetic or careless lab work, which will result in contamination of the porcelain surface. There is a contamination during application of porcelain on the metal coping, which will result in poor aesthetic. Uh, Thank you for your kind attention. And this is the reference, Rosenstahl and Godeker et al. Clinical Complication in Fixed Prosthodontics, Journal of Prosthetic Dentistry. Thank you for your kind attention.